Hello, everyone. Welcome to Spine Talks. I'm Dr. Rita Roy, CEO of the National Spine Health Foundation, and we are delighted to be here today with our expert, Dr. Larry Lenke, and his patient, Peggy. Spine Talks brings you unparalleled access to world-class experts, where we tell patient journey stories to help you understand the best treatment options available. We're going to start today by turning the program over to Dr. Lenke.
Thanks, Rita. So I'm Larry Lenke. I'm co-director of Spine and professor of orthopedic surgery at Columbia University in New York City. And my specialty is spinal deformity surgery. And I'm so thrilled to have one of my patients, Peggy, here, who's going to tell us about her journey being treated for longstanding adult scoliosis. And again, that she obviously went through a surgical procedure 10 years ago now. So we're actually celebrating her 10-year anniversary of surgery. And we're thrilled that she's agreed to talk to us about her journey from all aspects. And so we can all learn together about what's involved in being diagnosed with scoliosis, what's involved with considering and deciding upon having a surgery for this, extensive surgeries, we'll find out. But again, also how it's went to go through the surgery and how's the recovery and then life after surgery's been. So I'd hopefully talk about all that in the next 20 minutes or so. So Peggy, if you don't mind, just maybe from the beginning, kind of when you first were diagnosed with scoliosis, and I don't know, is it a teenager or was it during your adult?
It was a teenager. My mother was a physical therapist, and at about age 14, she determined that I had a little bit of a scoliosis, but she did not feel it was significant enough to do follow-up like at Gillette's Children's Hospital or something like that in Minnesota. Then at age 27, I was at work. I leaned over a bathroom sink and had such severe back pain, I passed out on the floor. Ended up in an ambulance at a local hospital, and they said, you have a scoliosis. At that time, I showed my mother, and she's like, that is worse than what you had at 14.
So showing progression already.
Showing progression already at age 27. Then by about age 40, I was standing next to my sister, and someone said, you're shorter than your sister. And I'm like, I am not. I have always been taller than my sister. And then I determined it was time to see a back specialist. So I went to a spine specialist. And sure enough, my curve had increased. I think at that point, I was like 37 degrees, and that would have been early 40s. And then fast forward, by age 55, I had a lot of symptoms.
Yeah, what kind of symptoms? Again, in other words, what we find often in patients with her type of scoliosis, it's kind of a slowly insidious process of, month by month, year by year, decade by decade, becoming more symptomatic and adversely affecting the quality of your life. So,
and people sort of accommodate for the, right? You just, because it's slowly creeping up and you slowly are making changes. You're not
good days and bad days, and especially if you're very active, you try and obviously keep doing your activities. Sometimes you have to modify them. So just curious, what was your process maybe the 10 years before you ultimately decided to have surgery? Just talk about that period of time, if you don't mind.
It was on and off. I would have a situation where I would be symptomatic, where my back, my mid-back, my shoulders, something would be hurting significantly. So I would go and have a massage. I would go to CPT. I exercised a lot. I've always exercised my entire life and found that it helped me physically and mentally. I do have a form of arthritis that the exercise just helps. As it progressed, my symptoms would flare up more often. And finally, to the point that I was periodically, not often, but having to take a steroid pack or something like that to get things to simmer down and get back into movement shape. I had this belief that if I exercised enough, I could outrun my scoliosis. Unfortunately, that did not happen.
Peggy, where did you get that idea from?
It's just one of those things that if I work hard enough, and I was kind of excessive in Pilates, strengthening my core, strengthening everything. I had done a 6-mile run 2 weeks before I slipped and herniated my disc. And I did it last minute. It was at the University of Wisconsin-Madison. And I just was convinced I could work out my...
Right. But I think that's an important point because a lot of patients can actually outwork their scoliosis if it's mild or moderate and minimally progressive. And that's actually the vast majority of scoliosis patients. There's actually very infrequently do they continue to progress to the stage that Peggy's back to.
And Dr. Lenke, don't you think all that core strengthening that Peggy was doing for all those years was helping her manage the progression?
Her progression, it helped her, as she's saying, mentally as well, which is so important. Yeah. And also, even whether it's realized or not, it helped her really get through the surgery in a better fashion and allowed her to do more even afterwards. So it's all kind of tied in.
That prehab that was baked into her life.
10 years ago, really didn't talk about much. But,
interesting.
It certainly helped her getting through the surgery early on and even long term as well.
Yeah.
So important.
I was doing a lot of reformer Pilates, but when I didn't have the reformer, I was doing mat Pilates, which I think actually is the gift that I received afterwards in recovering, being able to use my core smart, being able to use small muscles and keep myself moving after I had surgery.
Yeah, that's the key. Obviously, the surgeons think we do it all, but it's honestly, there's a lot of the patients do her and a lot of a partnership and a lot of therapy that needs to be done. So, I think patients need to understand that it's not just getting fixed and going about your life. I mean, there's a lot that goes into it and that patients have to put in a lot of effort, obviously before and after surgery. Obviously, during surgery, it's pretty much on the surgeon. Yeah. But before and after, it's really a lot on the patient. And I think patients need to understand that it's a big commitment.
Such an important point. Dr. Lenke, you've said to me before, we're going to do our part as the healthcare team. Right. Patient has to do their part.
Absolutely.
So it's really got to be a partnership.
Yeah. Right. So I'm just curious. I can't remember if I asked this specifically, but I do now. I ask every patient who comes to see me the first time, what triggered you to basically come see me? I'm a scoliosis specialist and, and you've had this for a long time, 40, 50 years. So what was the trigger that made you come see me as a new patient? Do you remember?
I do remember. Knew I was getting closer to having to do something surgically. And I had a friend who was with a medical device company and he took one look at my x-ray and he is like, there is only one man that's touching you. And that obviously worked out in my favor. The first time I saw you, Dr. Lenke, you basically told me how severe it was. It was just a matter of time and that you would be prepared to do surgery to get on the schedule now. I was not mentally prepared. As I was leaving your office, you said, you will know when you're ready. So 9 months later, I slipped and herniated a disc. Did some I had nerve impingement down my left side, and I knew I was ready. There was no question. And from the time I saw you, it was 3 weeks before I had surgery, which was unheard of. Yeah, on your schedule.
Right, exactly. Some of the cancellation or something.
There was a cancellation.
But then the point being, I think, for others that are dealing with scoliosis is that, it's important at least to get a good evaluation, to get a good understanding and kind of find out where on the natural history kind of curve or bell you are with your deformity, because not all deformities are the same. Again, some, and the vast majority, do not need surgery. Need a very comprehensive therapy program, maybe some other non-operative treatments like injections and Pilates and other things that can be performed to help you kind of manage your scoliosis. And it's actually very common that you actually do need a surgical solution, but if you do, you make sure you see someone who has expertise in scoliosis because it's critically important. It's a very complicated situation.
Yeah, and if we could just, Dr. Lenke, you said so many pearls in there, and I just want to tease out a few of those things. Many people are very afraid of having back surgery, and they feel that if they come to see a back specialist or a spine surgeon, that means they're definitely going down the path of surgery. But you just stated that oftentimes they don't need a surgical correction.
Right.
So it's figuring out who should have surgery and who shouldn't have surgery, and how do patients understand how to make those decisions, or even what questions to ask in that journey?
Yeah, I think, well, Peggy's perspective, my perspective is the way I approach it is my job is to educate the patient in front of me. So I'm giving them facts. I told Peggy, that basically, she had a very significant scoliosis that was going to continue to progress. We had documentation of progression. Her quality life and deterioration of quality life had correlated with her progression, which is very common, but not universal, interestingly. And so her natural history was just continued deformity progression and continued deterioration of quality life. And so there comes a point, again, her to decide, as I told her, where she realizes that she wants to get off that pathway.
Yeah.
And for situations with her degree of scoliosis, the only solution then to get off that pathway was with surgery.
Surgical correction.
But again, that's not that common, actually. It's much more common that you can get on a better pathway with non-surgical means and only have surgery as the last resort.
Mm-hmm.
But again, I think the key is for the physician/surgeon to educate the patient as to what their problem is, what the expectations are in the future, and what you can do short-term and long-term to get a better quality life. That's what it's really all about.
Yeah, it's that quality of life. And a lot of times people will ask me, I'm just going to put this off as long as possible. And that's not always the best advice, I think. And I'd love to hear your comment about, waiting too long. Maybe your options are worsening over time, that there's a time in there where there's a window that's optimal for patients. And Peggy found that window where you said, when you're ready, you'll know. But that's, again, no cookie cutter solution, and it's different for every patient.
So beyond educating, I also tell patients this is very common because I see patients in the spectrum of quality of life deterioration. Some are very early in their spectrum, but with a very severe deformity, and some are very late with an even milder deformity. But the key is that if the deformity is progressive, and over time, if we have documentation that their quality of life is deteriorating, then they do have a decision to make. And what we do know, unfortunately, is that as time goes on and as the deformity progresses and the symptoms progress, unfortunately, people age. And often the aging advances exponentially because they're less active.
Oh.
So we get to a situation where patients have now a more significant deformity, which requires more significant surgery, a bit riskier surgery, and they're not as healthy as they were 5-10 years ago.
Cardiovascular wise and everything.
So I'm pretty open about patients, telling them that's fine. You can decide when to have this, and I'm never going to force anyone to have scoliosis surgery.
Right.
But the bottom line is, if you wait 5 years, the risk of going through surgery are going to be exponentially higher, and it varies patient to patient. So obviously, based on their overall condition. But as I tell them, nothing gets easier or better for the patient or the surgeon as one ages with a chronic condition like severe scoliosis. Nothing gets easier or better for the patient or the surgeon whoever's doing the surgery.
Right.
It gets harder. So I think that's one thing patients need to understand. Again, that doesn't mean that that's the ultimate reason to have surgery, because because that puts a little bit of a prophylactic aspect to surgery.
Right.
But we do that in teenagers all the time. Right. So that's why since I do treat teenagers and children as well, I'm okay having that prophylactic conversation. It's not really a prophylactic. It's basically an understanding that, this is going to be harder for you to go through, 10 years from now than it is now. And so you just need to factor that in, because how were you 10 years ago? So you can kind of predict how you're going to be 10 years from now, because you're kind of seeing the slope, the deterioration in quality of life, and as well as the curve progression. So it's all kind of factored in. But again, the point being, it's the job of the physician/surgeon to educate the patient about all these factors for the patient to ultimately make the decision. Hopefully I did that for you.
Mm-hmm. I would like to add a little bit here. I have had the benefit of mentoring another patient that had a similar situation to what I had. It was a progressive scoliosis, and she had declined in height, I think 3 or 4 inches by that point. And every year it was getting more significant. And my situation was, I wish I would have done my surgery a year earlier. And so when I was talking to her, I said, this is what I incurred, I believe, because I waited. So if you've got a progressive scoliosis where you've been advised that ultimately you are going to have surgery, evaluate that seriously as an individual. with your team of people.
That's great advice. Because again, let's face it, no one wants to have the big surgery like this unless it's absolutely necessary. I've patients recovered for this for 33 years. I totally understand. At the same time, we do know the natural history of these curves. And as you found out, Peggy, it isn't good.
No.
Once you get to a certain point. For a small percentage of patients. But for those patients, we know what's going to happen.
Yeah.
And so if you want the chance at a better quality of life, it really is your best solution.
Yeah. And I think in that situation, one of the things that people say a lot is that surgery is the last resort. But actually, it's not the last resort if it's the right thing. And so it's for the right patient in the right circumstances. Surgery is a great thing, and it shouldn't be the last thing. It shouldn't be something that you put off until it's too late. So I think that's a message in there that I think is really important to convey to people, that there is a right time to have the right surgery. These are Peggy's preoperative and postoperative x-rays. They are an excellent pictorial representation of the magnitude of Peggy's curvature and the extent of the surgery that she underwent. The x-rays show a long-standing progressive adult scoliosis of 75 degrees in the frontal plane, with arthritis forming at the center and bottom of the curve, causing her symptoms. The view from the side plane shows overall good alignment preoperatively. She underwent a posterior-based total spine reconstruction from T3 to the sacrum and pelvis, with pedicle screws and rods used to nearly fully correct the scoliosis deformity in that frontal plane while maintaining her good alignment from the side view. She also had 2 cages placed from the back into the front of the spine with bone graft placed inside at the lowest 2 levels of the spine at her L4-L5 and L5-S1 levels to help stabilize and fuse those segments. This is helpful in these long fusion constructs. Her 10-year postoperative x-ray shows intact instrumentation with near complete scoliosis correction, well-maintained, and an overall excellent alignment of her spine.
The patients who have the greatest initial perceived benefit from the surgery are those actually that do wait and get to kind of a point of really no return.
Yeah.
Fortunately, their complication rate's a lot higher. And so it's a give and take. So it's not ideal. So that's why, ideally we'd rather have patients being treated with enough symptoms to warrant having a big surgery.
Right.
Obviously, documented progression, we know it's going to continue to deteriorate. But also, again, with a good attitude that with a proper surgical procedure and postoperative care, they can markedly improve their quality of life. Because that's ultimately what we want to do. Because if we just stabilize things and their quality of life doesn't improve, we don't consider that a big win for anyone.
Yeah.
So
Peggy, you came to see Dr. Lenke, and 3 weeks later, you were in the operating room.
Mm-hmm.
When you had your surgery and you woke up from surgery, what did you feel? What was that like?
Reality is, coming out of surgery, you are on so many drugs. It is just apps, and you're wired every which way but crazy. My husband was there, and thank goodness for him being calm and mild and kind of getting me out of it. There was pain, not that bad, but a nurse came in, and I wasn't even really happy with her. As my husband said, she was probably the nicest nurse I had had. It's a difficult journey for, I would say, the first 48 hours in particular. After that, you start noticing a progression of getting better and being able to do just a little bit more every day. The occupational therapy, some of the things that were provided to me in the hospital were so valuable, teaching me how to do everyday things. And I'm so appreciative of having those people to surround me that you orchestrate to make sure we come.
That is obviously a multidisciplinary team approach. I mean, there's a lot of people behind the scenes, probably people that you don't remember seeing that helped you kind of get
right.
This.
Yeah.
It takes, my quote to my staff is, it takes a village to prepare, perform, and recover patients from this kind of surgery. So it's not just the surgeon kind of gets all the glory if things go well and all the blame if things don't. But at the end of the day, there's a lot of people behind the scenes that help surgeons do what they do. And as patients realize that they're critically important to the success of the surgery.
Dr. Lenke, we're at a conference today. It's the 10th anniversary of this conference.
Right.
And in that theme, this is Peggy's 10-year post-operative visit with you. And I'm curious how things have changed in the last 10 years. So what Peggy went through, how is it different than what you're doing now? How is it similar to what's happening now?
That's a great question, because honestly, this symposium actually is called the International Spinal Deformity Symposium. That's a mouthful, so we abbreviated it ISDS. But it's really focused on scoliosis and other spinal deformities in adults. That's really what the theme of the meeting is. And so, what has changed in 10 years? First of all, what's not changed? Number one is that the indications for surgery are pretty similar.
Interesting.
Honestly, 10 years ago than they are now. We talked about progressive spinal deformity in the patients who are symptomatic from that with a deteriorating quality of life. Those key components are still the main indication that patients have surgery for scoliosis or other deformities in the adult brain. And the other thing that hasn't changed, we're still doing spinal fusion. So we're correcting the deformity into a better alignment, because we know that allows patients to have a better quality of life and have better outcomes when not only straighten the curves, but we give them a good shape from the side and do other things technically in surgery that give a good long-term result. But we're still doing a fusion. We're still basically, after we correct the spine into a better alignment, we're immobilizing all those vertebrae into one kind of stiff segment of spinal regions that won't ever change. The good thing is it won't ever change. Your scoliosis won't ever come back. But unfortunately, you lose kind of mobility to those segments. That isn't ideal. But we have not, to this day, been able to come up with a solution that allows us to correct deformity and maintain motion over multiple segments in the adult with good long-term results. So everyone still in the audience is still, all the surgeons we're still doing fusions. But we're getting better at it. Our surgical success rate for fusion is getting better. Probably the biggest change over the last 10 years is our complication rates are much less, both during surgery and after surgery. And that really is not a reflection only of the surgeons, but anesthesia is better, nursing care is better. And we created every center in the country that does this have created teams of carers that kind of focus on all aspects of the surgery. Even the preparation is better. I now have a program that everyone gets, and you didn't have this 10 years ago. We didn't have this 10 years ago. You get an initial evaluation by our physical therapist when you first see me, and then you're giving a rehab program to get in shape to optimally commit beforehand. Everyone gets prehab specific for you. Actually, I have a grateful patient actually donated a grant support to this, because that's one of the things you didn't have that for her. And she said that I wish I was in better shape going into surgery. I would have had an easier recovery. So she actually, her and her husband funded a program to allow us to evaluate every single new patient of mine to get a.
That's such an important point, Dr. Lenke, because oftentimes patients are in pain or they're uncomfortable, and so they're not moving. And so that prehab part is so hard to do. So getting a specific program for you to optimize anything you can before the surgery.
It's logical. If you're in better shape before surgery, you're going to have an easier time to recover afterwards, all things being equal, right? So that's critical. So that's changed dramatically. The other, probably technically, the thing that's changed the most is that now we have customized implants. So up until 4 or 5 years ago, basically to kind of put the shape of the spine together, every surgeon kind of took a straight rod and kind of bent what they wanted the shape to be and kind of put it in the patient. And probably the more senior you are, the better you were at doing that on average. But I'd been doing deformity surgery for 29, almost 30 years before I started using them, these custom, what's called patient-specific rods, which are kind of through computer engineering and machine learning. We kind of work with engineers individually, on a case-by-case basis, to create rods that are specific for the patient we're being treated. So they actually come to the OR kind of bent to the shape we want the spine to be in.
Wow.
So even in my hands, after 30 years of doing this surgery, I've reviewed now my results before using these custom rods and after, and my rates of complications have dramatically decreased. So point being, that's why I tell even the junior surgeons, if they can make me a better surgeon after 30 years, my goodness, it's probably going to help you as well. See, that's one of the biggest changes, and that's been made, at least in my practice and many other holding surgeons' practice the last.
It's interesting to think about personalized healthcare coming to spine,
right?
And how does it manifest in the spine, right?
Very practical way.
Yeah.
It makes sense. Obviously, so I'm deciding on your shape of your spine, not during surgery, but, several weeks before the surgery, I'm looking at a computer screen and I'm shaping your spine to what I want it to look like. And then basically we have algorithms that kind of tell me whether that's going to be green, yellow, red. Is that a good shape, average shape, or, not very good shape? And so it's very
planning.
Planning is being critical, and then again, planning and then execution is easier, because then if I hit my plan and put these rods in the patient and the shape is maintained, then we know we've kind of executed on our plan.
Yeah.
So we can confirm that. And up until several years ago, we had no way of confirming that.
Yeah.
So you would think we'd do that, but we weren't. No one was doing it. That's still not being used in the vast majority of surgeons surgeries in the world. So, but slowly over time, this technology is going to
adopt,
because it just, again, it makes sense, and it's been proven that the results are much better.
One of the things that patients ask me about, and Peggy, I don't know if you've had this thought as well, is that technology does continue to improve over time. And so patients sometimes think, well, I'm going to wait because the technology is going to get better. What do you say about that, Dr.
Yeah, that's a very, very common question. And so honestly, I'll answer what I just kind of mentioned here. 10 years from now, I think we're probably still going to be doing spinal fusions per your condition. I think number one, we're probably going to be doing a better job of getting you in the more perfect alignment, which is of critical importance on how you do short and long term. Our rates of getting you fused, since we are still in fusion, are going to be much higher, which they've been improved every several years. Are improving, they've been improving in that as well. So that's going to continue to improve, and our complication rates with the surgery are going down. So I think that trend is going to continue.
Yeah.
Hopefully, the holy grail is that we can start doing these surgeries and keep motion and mobility a little bit more to some of the spine, either above, below, or both, or even all in between. That's what I call a BHAG, a big, hairy, audacious goal, honestly. But that is a goal to keep the spine corrected and more mobile is the ultimate goal. But boy, I currently I tell patients in my career lifetime that's not going to happen.
Yeah.
Maybe in some of the very junior surgeons are just starting off, that may happen 30, 40 years from now. But that's good. That's a tough goal. We've been working on that goal for a long time. We haven't solved that yet. But so again, I think the bottom line is I tell patients, if your quality of life is at the point where you're really struggling, nothing is going to change the next 2 to 5 years that dramatically to change how your surgery is going to be performed or the success rate of surgery. So it probably isn't worth waiting.
Yeah.
If you're 22 years old and have a curve that you're not bothered by, that's been minimally progressive, I don't encourage those patients to have surgery now. I say, we probably will have something by the time you're in your late 50s. I think when you had your surgery, Peggy, that's going to make a difference in how the surgery is being performed or the results of the surgery. So that's, again, a nice perspective of I see children and adults that I'm telling certainly my younger patients that, again, have, curves that aren't necessarily need to be operated on, to hold off, because things will change.
Interesting. And that multidisciplinary approach to optimizing the patient before surgery, and then some of the things happening after surgery, coupled with some of the masterful techniques that are getting improved, is just creating a better and better picture for patients. With that said, Peggy's had an amazing outcome.
Mm-hmm.
So first 48 hours were tough. You were in the hospital for how many days, Peggy?
I don't remember. Probably back then, probably 7 days. Was that 7, 9, 10?
They were short rooms and I had help. So we were out in, I think it was 4 nights.
Well, it's 10 years ago. That's amazing. Well, first of all, that's not anything to do with my healthcare team. That's totally on her.
Great patient selection.
Grady.
I passed the PT, and in hindsight, I was like, hey, I probably should have flunked the PT. However, we were staying at a very nice apartment across the street from the hospital.
Right.
and they're
Right.
really close by. So I did not feel like I was abandoned. My husband was there. My brother was there.
Lots of help.
Two of my sons were there.
Lots of support.
So we had a lot of support there. Subsequent to that, we flew back to Minneapolis. I believe it was 14 or 15 days after I had surgery.
Wow.
And the whole process of getting to the airport and stuff was seamless.
It's amazing.
The staff brought us to the airport, we were fortunate enough to fly first class home and
Good.
stuffed in with pillows and stuff. And got home and, my whole goal while I was flying home was to be able to walk up our driveway. And it's fairly long and it's got a hill. And that day I did not, but the very next day I walked right up that driveway. And then every day I had a goal to go just a little bit further, a half a block, a quarter of a block, whatever I could make. Dr. Lenke told me I should be able to walk a mile at the end of my first month, and I was able to exceed that. I think one of the things that was a blessing for me is I had so much sacrum pain from I couldn't stand. I could barely walk at the end because there was so much pain
Before surgery.
before
Right.
surgery, and that was literally gone.
Right.
Wow. And
That gives you hope at least, right?
it gives you hope. So,
You say obviously incisional pain and still pain from pre-op pain, but at least it gives you positive hope that
Yeah.
something has made a difference. So
Yeah.
but the surgical pain by that point, when you're able to walk the mile or two, has really subsided, and you're really focused on, I don't have that other pain anymore, and this is a terrific thing. And so, fast forward at 1 year, I was able to ride my bike 25 miles. It was a goal.
Wow.
I've downhill skied. I
That's it.
have
yes, incredible.
ridden bikes all over the place.
So yeah,
I-
you haven't seen her X-ray. She had a total spine reconstruction from the upper thoracic spine just below her neck all the way down to her sacrum and pelvis. So this is an extensive spinal reconstruction. So to be able to do that, yeah, actually, we just published a manuscript and I'm returning to skiing after these surgeries, and people do it amazingly.
That's
We
incredible.
didn't even realize people could do it, honestly, but we let people do it who have done it before, and they can amazingly. So it's just
Did you feel fragile at all, Peggy? Were you afraid of feeling fragile, or did you feel strong? And if I fall, I'm going to be okay.
I think I can. I know I can. I mean, there's no other way to say it. That's the way I felt. And I think that I approach a lot of things that way. But reality is, it felt so good to be outside, to be on skis, to get a little of that cold air coming your direction, that that was worth taking if there was a risk.
trust me, I know there's a risk skiing. Elbow made the ski injuries, but I'm still back doing it because I love the feeling.
Enjoy it.
Right, or exactly.
And I do believe I ski more cautiously. I don't do any bumps.
And maybe that would have happened anyway, as over time, as you get older and a little more cautious.
Maybe we're a little bit smarter.
Right. But the point being here again, obviously not all patients. Maybe is unusual, but not so much. Honestly, if you are motivated and have obviously a good surgical result, really there are no limitations we put on patients. It's really up to the patient to decide. Sometimes obviously modifications. She's not skiing bumps anymore, but she's still skiing.
Yeah.
She's not doing the same Pilates she did when you were 30 years old, but you're doing Pilates. So in other words, as long as you're willing to adjust to things, you can have a very good outcome with really an unlimited activity level based on what you want to do. So I think the key message for patients to understand.
Yeah. And I was just going to say, and you compare that to some modifications of life, but the alternative is disability, ultimately,
So right.
in a progression, like what
So 10
Peggy-
years from now, you think you'd be able to do the things you're doing now without surgery?
Never.
Right.
Never.
At the end of the day, that's really the question that has to be answered, because the main goal of surgery is to improve quality, optimize your living. As we're all going to age, we're all going to slowly do a little less, but as there's a lot of good health data that we have to stay active as we get
Right.
older,
Yeah.
right?
Yeah.
So
And I was going to just say, Peggy, Dr. Lenke just said the goal of surgery is to improve lives. That's what we, as surgeons, we improve lives. But I, having been a spine patient, and you're a spine patient, I would say it's more than just improving my life. It was saving my life. And I think that's a new way of thinking about what spine surgery does for you, is that, aside from the secondary health conditions that happen when you stop moving because you're in pain, it's reclaiming all the things that you gave up on and that you feel like in some ways parts of your life have ended. And so I feel like it's really saving a life, not just improving or restoring a life. I don't know if you feel that way, Peggy.
I do. And I do believe that one of the things you learn as a spine patient are what your limitations are and what you should and should not do. And I've had to be reminded of the things that I should not do on more than one occasion. But reality is, I do a program at least 3 days a week that is basically, I climb at incline on a treadmill. I do power walking, I do rowing, and I do lifting. I don't lift anything over my head, and I will not run anymore. I stick to the power walking, but I feel like that gives me at least a great sweat, and I need a great sweat in order to feel good and function well. And I'm appreciative every day that I can still do
How's
that.
the rowing?
I've gotten better at rowing, but I think that I've learned more about my core engagement on the rowing, and not the hardest thing for me to do, because I'm short anyway, is to get my feet in stirrups and pull the barrel. That's the hardest. Once I get going, I am great, but that is the hardest part. And that's the spine is not movable, so you can't do that. But there are workarounds. And one of the things that I found amazing is that your brain adjusts to all those workarounds almost instantly.
Right. Again, as you can imagine, this is an exceptional patient here, doing what she's done after the significant surgery. And that doesn't mean everyone has to do all this.
No.
Again, but
No.
we have patients who just want to go play 9 holes of golf after surgery. They can do that. Well, what's the bottom line is,
Absolutely.
if you are motivated to get back to things you enjoy doing, again, with the right diagnosis, the right surgeon, and the right recovery, you can get back to do those things, whether it's a smaller surgery or a larger surgery.
Yeah.
That's patients need to know that.
I think this is such an amazing conversation, and it really underscores the relationship that a surgeon creates with a patient. It's a lifelong relationship. And Dr. Lenke, just so amazing for you to take the time at this busy meeting and to share Peggy's journey with us. Would you say this is a common thing that happens? Do surgeons get to see their patients this many years?
Well, they come back and see us, but we were just saying about that. Again, bottom line is, it's an absolute honor to first of all, take care of someone like Peggy. I mean, that's really the greatest joy in my 33-year career, is seeing my patients back and seeing them doing well. There's no reward greater than that. Let's face it. We're financially reimbursed to do the surgery and take care of people, but at the end of the day, I mean, there's no greater satisfaction is obtained by seeing how well patients do and be able to change someone's life. I know I've had some health issues, but you don't have your health. Life doesn't matter what else you have.
Right.
It's such
So it's just an honor, and not only myself, but all the 200 plus surgeons here. That's why we're here. We're trying to do our job for our patients. But it is really just a complete honor, and to see patients back. And again, the more senior you get, I think the more reflective you get on that too. In the beginning, you're just trying to make a living and just stay out of trouble, and you're kind of learning the ropes. Yeah, I kind of know how to do this now, and you kind of look at it from a different perspective, and really get a lot of satisfaction from seeing patients back. I've had patients come back at 30 years post-op, and it's incredible. And so, that's really one of the great things about being a physician and surgeon, is helping people with any medical problem.
Well,
that's why we do this.
Well, for sure, it's a calling, and there's it's clear why we call our experts healthcare heroes, honestly, because the incredible work that you do for people you dedicate your life to help other people is it's such a gift. And we're all just so grateful that there are people like you who find joy and find a calling in being able to help people like us,
Yes.
just get back to doing our lives. It is truly a privilege for me to be able to have this conversation with you, Dr. Lenke.
Might as well. It's a good shout out to my family who, honestly, they're the ones actually that have to suffer. It's not for me. It's a pleasure to come to work and help people. Well, unfortunately, there's some people that suffer because of that. So, but thankfully, they understand what I'm doing as well and the good I'm doing. So it helps my wife and my children to understand it as well.
It's pretty amazing to think that we've been talking about the partnership between a surgeon and the patient. The surgeon and their surgeon's team does their part. Patients have to do their part too. But what we've sort of talked about today is the support staff that helps each of these partners do their part. And Peggy, you've talked about your family. Dr. Lenke, you've talked about your family, your work family, and your home family to support, the work that you do. Peggy, tell us a little bit about the team that was helping you when you got home. I know you had family here in New York, and then you traveled back home. What did that picture look like? What advice do you have for people?
Well, my husband was my primary caretaker. And then this is crazy, but my best friend from 8th grade moved in with us every week from Monday to Friday so that there were 2 of them. And she's got a medical background, but she moved right in and helped prepare meals and take care of me and make sure I was out walking with someone. So it gave more time. It was in the summer. We happened to live on a lake in Minnesota because there's 10,000 of them. And my family was there. My children were there every weekend, so my friend could go home, and they kind of took turns coming in, preparing meals, doing stuff. And for as difficult a time as it ended up being a pleasant time because I was surrounded by people that I loved. And I could never appreciate it or never say thank you enough to all of them, as well as you, Dr. Lenke, and your team. And I'm going to give a shout out to Angie because she's my person.
Yeah. My clinical nurse, Angie Smith, has been with me over 15 years now and really is a primary conduit of patients kind of getting ready for surgery and recovering from surgery in my practice. And she's just an angel, Angel Angie. So
Angel Angie.
She is.
And that also just, again, points out something as patients are meeting their surgeon and the care team. Peggy, you talk about the amazing experience you had with Dr. Lenke's team. As a patient is choosing their surgeon, meeting the team is a very important component of selecting your care team. And that when you are a patient and you're trying to decide who is the right surgeon for you or how to find the right doctor for you, feeling good about the team is very important as well. And I think, Peggy, you shared with me that, as you were meeting Dr. Lenke and his team, that whole picture gave you a lot of confidence going into your surgery.
It did. And Dr. Lenke doesn't do 5 of these surgeries a year. He does a couple of them a week. And that is a huge difference in my world. I had every confidence in the world that I was with the right person because he specialized in this type of surgery. And regardless of where you go, I think it's important to determine and find the right person who specializes in it. I didn't want to leave town to have surgery, but I knew it was in my best interest to leave town to have surgery.
That doesn't always have to happen, but it depends on what your problem is. And
Right.
But again, spine surgery, similar to what happened to orthopedic surgery 30 years ago, has become so super specialized. I mean, 40 years ago, if you had, you saw an orthopedic surgeon, he may do a wrist operation one day and the operation the next day and a spine operation the day after. And obviously that went away 30, 40
Does it
years
happen
ago.
anywhere? Yeah.
Similar in spine surgery, now we all have our subspecialties, especially in a big city like New York City, where there's some commonalities of conditions, lumbar disc herniations or cervical stenosis that many different types of spine surgeons can take care of the condition. But then you get to more esoteric conditions like the progressive adult scoliosis or spinal tumors or other things that really surgeons all focus just on that pathology. And so if you do have these advanced conditions, it may be worthwhile to do some research and kind of find a specialist who does things in that area routinely.
Yeah.
Again, obviously there's lots of factors involved as we've talked about, but
Yeah.
it probably is worth at least one visit with a specialist in your condition to just get a different perspective.
Right.
You may realize that it is better to travel potentially. Not again, that's not necessarily all the time, but
Right.
just keep that in mind.
And now telehealth is generally offered, so
Right.
people can
Exactly.
do consultations with
Great
different
idea. Right.
different care teams and make a choice and get multiple opinions.
Exactly.
It is a big deal. Whether you're having your full spine fused or one segment,
Right.
it's
Be comfortable with your surgeon and their team.
And the
Right.
team.
Exactly.
in the team.
Good point.
So we've talked about your journey, Peggy, your diagnosis, finding your surgeon, going through surgery, your recovery journey, and what would you say now? You're 10 years out of your surgery. Your life has been improved, and you can't imagine not having done it. But how do you describe that?
I was given a gift of a good spine again, and the ability to do pretty much everything I want to do. I would say everything I really want to do. At the end of the day, I can pick up my grandchildren, I can play with them, I can get on the floor with them. And those things wouldn't have been possible without doing this surgery. And I am forever grateful to you, Dr. Lenke, and everybody else that really played a part in helping me get better. And I couldn't thank anybody enough.
Appreciate that. Again, as I said earlier, it's an honor to take care of people like Peggy and so many others that have been fortunate. My team have been fortunate to take care of. So it's why we do what we do at the end of the day.
Thank you, Dr. Lenke. You've given us so many insights into 10 years ago doing surgery, now doing surgery, the future of surgery. You have been at the forefront of innovation in this field for many years. We are so grateful for all the ways that you've contributed to patient care, to future patient care, and taking the time with us today to talk about the patient journey so that people can hear from real patients in their own words the truth about spinal health care. It's not an easy journey, but there is good news in spinal health care. Whether it's an operative pathway or a non-operative pathway, there is good news, and we're here to share that good news.
Absolutely. Yeah, I can only personally help one person at a time, but that's why I do courses like this and educate the future surgical community that ultimately then we can have an exponential reach of getting appropriate, accurate information out to everyone involved in this very highly specialized part of spine care. So very important.
And Rita, thank you for your help in making this all happen and bringing us all together.
As well as
so appreciate
Spine Health Foundation with obviously be the CEO. It's a great organization. Thank you for sponsoring this, Rita, and the foundation. So we need to spread the word, right?
Spread the word.
Yeah.
We live in a world where patients are expected to be part of the decision making.
No need to be part.
And need to be part. And so we need reliable, trusted resources. And when we can have world-class experts like Dr. Lenke that are giving this information out, it's trusted, it's reliable, and it's honest. And that's what we are here to do, is to share that information. And Peggy, if you're like me, and I think you are, when you have a successful outcome and you really didn't know what to expect, you just want to tell everybody how great it was. Why did I wait so long? I shouldn't have waited that long. None of us have years to throw away. So get better and get back to life and get the right treatment. I'm very passionate about that message.
Both are wonderful, great examples.
Peggy, thank you for traveling to be with us today.
Exactly, yeah.
Thank you.
You both. I really appreciate it, and it's been a great
Great session.
Great session.
Yeah.